Good afternoon. I'm Patty Howard, and I am the emergency nurse representative here today, and it is truly an honor to have been It truly is an honor to have been invited to be part of this, and I really feel very blessed because many of the things that have been said here about things you need, I feel like I've been fortunate to have. I have an extremely supportive administration. When I was in a truly nurse researcher role, anything I said to them, let's try to do, they let me do it. Our chair of emergency medicine, I'd go to him with these ideas and he'd say, absolutely, let's do that. And then as it became very apparent that I wasn't going to be able to stay in that role, that I was going to have to go back to operations because I'm now the operations manager for emergency services, I'm still very fortunate to be able to do some research as well. And my involvement with SBIRT actually started in 2005 when there was an RFA that the Emergency Nurses Association put out for 5 hospitals to see if it was feasible for emergency nurses within the constraints of their work to actually perform screening brief intervention. For alcohol predominantly at the time was what they were looking at. They had a project together with NIDA, and so we were lucky that the University of Kentucky was chosen to be one of the sites, and there were 4 other sites, all well-known centers across the country. Now, just to tell you a couple things about the University of Kentucky, we have 2 campuses within Lexington in a 1-mile radius. That's only been since 2007, but it has some bearing on things I will tell you today. In 2005, we only had the academic medical center. We had a 40-bed emergency department, and we saw about 50,000 visits mixed, both children and adults at that time. In 2007, we acquired a community-based facility down the street that was seeing about 12,000 emergency visits a year, had 100 beds open, although they had a certificate of need for more. We purposely bought them to funnel our low acuity patients, and inpatient psych is there as well. So you know where a lot of patients go now, don't you? And so we purposely did that to keep the sicker patients at the academic campus. And in the interim, we've built a new facility. So when I started this research in 2005, I was in a 19,000 square foot emergency department with 40 beds, seeing about 50,000 square feet, or 50,000 visits. And then in that time period, we started ramping up to build this new facility, which we moved into in 2010. And remember, in 2007, we acquired the hospital down the street, and in 2010, I had 40,000 square feet, 62 beds, of which 18 are the pediatric ED and the rest are adult. I moved in seeing about 52,000 patients a year, and in 3 years, we're seeing over 70. So a huge growth and a huge change. Likewise, our community facility down the street is seeing 20,000 visits. So between our 2 campuses, less than 1 mile apart, on the same physical campus, we have 90,000 visits. And that will become apparent why I'm telling you that in just a few minutes. So I did that initial study, and we in 5 months screened over 2,600 patients compared to the other 4 sites together that screened 575. And so they came back to us and said, gosh, you've shown that emergency nurses can do this. Will you do an outcome study with us in NIDA? And we said, sure, we'd love to do that. I'll figure out how to get it done. And as part of the initial grant, 2 nurses were actually sent to Chicago for a 2-day brief motivational interviewing workshop. Don't forget, it was 2 days. I paid attention. So they did that, and they came back, and the 2 of them and myself were actually the ones that did the initial patients. And our nurses didn't like that because they didn't want to be left out of anything. You know, emergency nurses are very competitive. They don't want anybody else to be able to do something that they can't. So over time, before we did the second study, the outcome study, we had to have all of them do human subject protection training. We had to train every one of them to be able to do brief motivational interviewing and all the components of this ourselves internally. So that's kind of our history, and I'm going to kind of bring you up to where we are today with where we started. Maybe.
To the right. To the right.
To the right? Okay, different. All right. So how does this work for emergency nurses? You heard a lot of things about flow. Flow is critically important. Let's face it. Patients don't come to the emergency department to see me. They come to see the providers. That is not me. And for me to do screening and triage keeps them from seeing the provider. So we quit that pretty quick. We figured out very, very fast that kept us from getting the patient to the provider. So we don't do it that way. We do it as part of their secondary exam and when we do the rest of their screenings. And you'll see that happens very, very quickly in our system. Emergency nurses have to understand the why. And so in the beginning when we said to them, we're a level 1 trauma center verified by the ACS, and it's coming. We're going to have to do this. It's not going to be an optional event. We need to figure out how to do it because we want to be able to participate. We want to be able to improve the care of our patients. And I presented to them all the literature that I opted not to put into my presentation today because I felt fairly confident it was going to have already been talked about before I got up here at the end of the day, and it was. And so That literature, though, is more than the average emergency nurse wants to know. They want to know two things, which are the very last thing at the bottom of this slide. What's in it for me? It's going to reduce alcohol-related injuries, which matters to the emergency nurse just like it does to every person in this room. And in theory, it's going to reduce emergency department visits, although you sure can't tell that where I work, because we have plenty of patients. The other thing that's really important, and Carrie alluded to this just a few minutes ago, is champions. You have to have administration that supports you. And in the beginning, you heard, I was the nurse researcher. I had zero power. Today, yes, I have the ability to influence the staff, but in the beginning I didn't. They wanted to do it. And I asked for staff champions in addition to the 2 that went to Chicago. I had so many champions, I had to tell some of them no because they wanted to be involved and they wanted to do it. And those 2 things, I think, are key in the success that we've had. So there was a lot of discussion about what do you do from an ongoing basis. Well, on an ongoing basis, we provide training 4 times a year. So we know we don't get everybody when they start, but we have 2 big hiring peaks. And so still today, all these years later, which I realize it's not all these years later, but 8 years is a day or 2 in our lives, I personally do these trainings. Now, I am actually in the process of handing that off because one of the things that we do to make sure that they maintain the skills is we do direct observation of their brief interventions, because that for us has been more successful than other things we've tried. And quite honestly, some of our staff that do brief interventions, I've learned from. So they've really learned how to do this, and they do a really good job with it. And so they've got a very clear role. And what we see, and you'll see why I know some of this in terms of numbers, is we can see when new nurses are uncomfortable because some of the numbers will fall, and so we'll insert champions to work with them because the new nurse has a hard enough time trying to figure out how to manage the patient, much less how to ask people if they want to change a behavior. And so we found that they really have to have the support of a champion, and so that training and support is really critical for that to work, and they have to see us do it. So today, or last week on Thursday, when I spent most of my day in the trauma bay because I don't know where the patients came from, but they came, every patient that I personally touched got screened because the staff need to see that I do what I ask them to do. I'm not going to ask them to do something that I'm not going to do if it's appropriate for the patient. And then it's got to be easy. And you've heard a lot about IT solutions, and I don't say ours is perfect, but I think that we've been very fortunate in that in addition to the administrative support, our IT has worked with us. Granted, it's because they want us to be the guinea pigs for everything else they do, but it worked for us for this. So as you can see, I don't know how well you can see that up there because I can't see anything with my bifocal contacts from the side. So I'm going to try to look right here, and if you look, you can see that this patient screened out at never on drinking, and so no further screenings needed, done. It moves them right through. They don't have to click any boxes. They don't have to do anything. If they'd responded appropriately, it would have pulled up the next several boxes that needed to be pulled up. So it makes it very easy. So the patient that's immediately bedded, the nurse doing that secondary assessment, gets this screening. And you'll notice here it's got other screenings. It talks about tobacco. If you look down below it, it's got your street drugs. It goes on to have suicide. So we've got all the screenings someplace obvious so that the nurse can't miss them as part of their care, because that's really made a difference for us. Likewise, one of the things that matters, and you know, if you work in an emergency department, you understand no one looks at your chart after you send them upstairs, right? Whether it's the physician or the nurse. Nobody pays any attention to what you did in the emergency department. Did you do something for the patient? So our documents pull into the inpatient document, which has been a huge success for us, because I'm sure it doesn't happen where you work. We have a phenomenal number of admitted patients that stay with us, and so to meet that inpatient standard of care, they don't have to do rework because it's in that inpatient document. And then the nurses upstairs are happy because now they don't have to screen. So it's a win-win for everybody. And in addition to that, our core measure nurses, who also do SBIRT and come to my training and do the brief interventions when the alcohol counselor is not available on the weekends, also can document in the same location, and it goes back and forth, which makes it really helpful for us. Now this, the other piece that's helpful is, and you can't, it's not really intuitive from the screenshot that I took because I was trying to, redact information and, not show anybody's private information. Once I put in the right answers, it will automatically go ahead and screen them out as somebody that needs to be counseled. So we developed ASN for negative, they don't drink, ASC for counseled, which is our brief intervention, and ASR for referred. And so that's how we know what we have to do. And so then the nurse would then come back and do this brief intervention. Because they screen them, they may not do the brief intervention right at that minute, because it is all about those moments when they're waiting, because as we've already established, no patients wait in your emergency departments, I'm sure. So when they have those moments is when they do those interventions. So how have we sustained it? Well, we've sustained it because the staff owns it. And that's probably been the most important thing for us. And it's so sustained that I don't think our residents understand that it's something that we didn't do before. The residents that we have now, the current generation of residents, has no idea that that's anything that we didn't ever do, because they just assume that those screenings, that intervention information is going to be there for them because our documents pull into their record. And so that makes them really happy too, because the vital signs and everything we've done pulls right into their record, and they can choose to accept it or choose to delete it, and it makes it really easy for them. The Joint Commission standard for inpatients, our enterprise has said at both campuses, we're going to screen all the patients. And so in 2011, mind you, I told you, in 2007, we had brought Samaritan on board. In 2011, when they went live on the electronic record, they all got trained so that they could do them. And that was a huge help for the behavioral health intake nurses, because they'd been doing it at that point, and it actually slowed down their getting psych patients upstairs because they were trying to do double dipping. And then obviously you already have heard enough about level 1 and 2 verified trauma centers, so I don't need to talk about that. But one of the things that's helpful to nursing, you know, nurses like to be recognized. We like to know that we've done something that makes a difference. And I don't know how many of you know about the Emergency Nurses Association Lantern Award. It's like magnet for the emergency department. This is a perfect example of something that is nurse-led, that is evidence-based, that can be one of those vignettes for your Lantern application. We were fortunate. We were one of the first Lantern hospitals. We're up for reapplication. Yuck, but have to do that. And then magnet status. These are the kind of nurse-led interventions that Magnet likes as well. So these are easy ways to get nursing to buy into actually doing this. So how do we monitor implementation? How do we make sure what we're doing is effective and they're not just filling out the blanks? I've already alluded to the fact we do real-time observation. Myself, the other manager, who interestingly enough was one of the original nurses that went to that training in Chicago all those years ago. He has ascended up through the ranks. We do real-time observation, so we both obviously are knowledgeable about it, and our champions help us. And then we have a lot of monitoring of our actual processes. And when we notice there's late adopters, we address it. So if you look at this daily screening, don't think the math is going to work out, because this is all screening. So it's not just alcohol and substance abuse, it is all of them. But if you look at this, and I glance at this particular day, because I get this report at 5 a.m. every morning, 96 patients had a screening question out of 214. That math doesn't work out quite right. Well, at our facility, they only let us screen above 15, because that's who goes to the adult trauma population. The pediatric trauma surgeons haven't said that we're going to screen those 12 and up like we do for suicide. So when you take that down, it's only 156 that were that age out of the 214 we saw that day. And then when you think about the fact that some of them, because of mentation, or you know, they were too sick, or they went emergently to the OR, we probably didn't get screened, that's still not enough. So I have to go back and see who was on shift that day. Well, it's not so much who was on shift that day, it was how many patients were in the hallway. Because, you know, I told you I have 62 beds. I've had to add 25 hallways. I have 87 beds. Yes, it's not really fabulous. But they won't screen in the hallway for obvious reasons. And so if the only flow I had the day before is hallways, because I had 30 admitted adult patients, I'm going to lose on screenings. And that's the trade-off. So if I can't get patients upstairs and get them out of the emergency department, I'm not going to be as good at screening. And so that's something that I know for a fact. And I can't fault them. It's a privacy issue. Conversely, every day on that same screen, if I drill down, if I want to see what got missed, this actually has patient and nurse information that I took out. And it actually tells me, so I can go in there, and if I see that Susie has no screenings for her patients, then I'm going to go back and say, Susie, what's going on? But typically I see a fairly even issue, and it's going to be about things like the hallways, or it might not have been the patient was unable to communicate because they were intubated, things like that. So I get great level of detail on the screenings as well. I also get a monthly screening report, so I can get it all rolled up. So I get a lot of data out of our electronic health system, and it tells me a variety of things. And again, if you try to make the math work, it doesn't, because if you don't answer every question, even if they're negative, they count it as incomplete. Now that's a logic I haven't been able to get IT to fix yet, because obviously if they say no, they don't drink, then they're going to screen negative, and I should have them incomplete. But the reality is that's one of those things I have to work on with IT still, and I've learned to work around it. The other thing is somebody talked about when you have changes in your system. Well, when they change other parts of our enterprise system, because it goes across the entire system, including our ambulatory environment, sometimes it has unintended consequences, like it says there's no max drinks noted here, even though you saw the page before had them. So I had to go back and have them fix that logic. So those kinds of things can happen when you have changes to your application that you don't think about having any effect on your daily work. So what about the ED nurses' experience? What have we learned? We've learned that collaboration is essential, because out of that initial screening, that pilot that we did back in 2005, they gave us an in-house alcohol counselor. At that time, we had nobody in-house that was a substance abuse counselor. We've since gotten an outpatient counselor as well. We've also since gotten emergency department social workers from 7 a.m. to 11 p.m. 7 days a week as a result to help with some of these very complicated patients. If the patient gets admitted and they screen as ASR referred, there's an MLM, and don't ask me what that stands for, I'm not techie, but there's something behind the scenes that drops an order for the alcohol counselor to automatically see this inpatient, so I don't have to worry about that. What does not work? Hallway screening. I've already talked to you about that. What can we change? We've had to really get them to use their waiting time effectively, because let's face it, there's not a lot of downtime in the life of anybody in the emergency department, and so when they can sit down and catch their breath, they really don't want to have to get up and go do something else, but we've had to really help them see how important it is to go do interventions when the patient's waiting and they're waiting. And I realize that's not a lot, but they actually have found a way to be very effective and get it done. And so resources, I didn't really talk about the fact that I actually was on the team that did the ENA Expert Toolkit. Is actually a really good, got really good resources out there for emergency nurses. And these are the publications that came out of the pilot and then the outcome study. And the one thing I did not say about the outcome study, and I fear I'm out of time, is in that 6-month period of the outcome study, with all of the nurses that we had, we actually screened 5,000 trauma patients predominantly. There were a few illness patients in there. Out of that 5,000, 1,000 screened, 973 screened positive, and 104 agreed to participate. So not a very good agreement rate. And in this world that we live in of disposable cell phones and hard to contact people, and the fact that only 30% of our patients come from within our system, so they've come from another system around us, because we're one of 2 trauma centers for the entire state. So we get half of the state's patients, and so many of our patients don't get follow-up with us. Even with signed consents, I had trouble getting follow-up information about some of the, did they seek care and have injuries. So we only had complete data on 40 out of 104. So that was one of the pieces to the outcome study that was a little disappointing. So on that note, thank you for inviting me. I really appreciate your attention.